Hello and welcome to Chapter 9 Key Highlight Video, Assessing Individual and Environmental Factors. This is the core of our assessment. Chapter 8, last chapter, explained the purpose of that assessment. It's like, why are we assessing for that, right? This chapter is examine what we assess and how different areas of the client's life interact. This is the biopsychosocial spiritual, and we'll talk about it today. Now, the core message that I have for you guys, we do not only ask what's happening or what is happening within the client, we also ask what is happening around the client and between the client and their environment. In every single video, we've been talking about how the individual or the person is part of an environment because the problems involve multiple systems. The problem is not happening on its own or within a system that is way out there or away from the others. It's actually influenced by many systems, including the client's family, the client's health, the client's school, work, housing, community, economic status, class, race, gender, religion, social policies. Those are all really impacting the problem as it isn't existing in isolation. We ask what is happening inside the client or around it. Sometimes chronic pain could be related to work stress or life stress. It's not on its own. Patient isn't just anxious. Patient isn't just depressed. They're all interrelated with each other and they impact each other tremendously. Okay, implicit bias. Implicit bias, this is when an unconscious assumption is shaped by our background or by experiences. This is when we notice when bias can affect when you're biased against a belief, for example. It can affect how you notice the problem or what to ignore or what to not ignore or what to bring to the surface. So you need to pause and ask yourself, what am I assuming here? Or am I imposing my meaning? Or am I imposing my beliefs? Am I letting my values coming into the situation, into that relationship, that it is just the clients, right? Bias awareness isn't about guilt. It protects a client from being misunderstood, but it also protects you. So it doesn't only protect your patient or your client, it protects you from burnout, from crossing a boundary, being self-aware, so you can check in and examine those inherited biases or beliefs, okay? Assessing individual functioning. This is when we look at the bio model, the biopsychosocial spiritual. When we discuss the biological model, this is when looking into disease, physical health, mental health, pain, sleep, family dynamic, not family dynamic, family of origin, how many siblings, your birth order between your siblings, all of that. We're talking about biology, more of a biology. Now, my biological section when I did Peds Hospice was completely different from my biological section right now in the emergency room. With Peds Hospice, I'm looking into diagnoses and the prognoses. We're talking about genetics, because those are terminal illness, and most of those terminal illness has been caused through genetics. So we examine that in the emergency room. My biological is looking into where the patient is medically at, medical readiness for the disease or the symptoms that they've come for it to be seen or to be checked or examined. That's my biological section. Are they feeling okay? Are they in pain? Are they not? Did they ask for any pain medication while I'm in there? Do I need to let the nurse know? That's my biological section. Now, when we're talking about psychology or psychological, this is we examine mental health. We examine whether the patient is suicidal, homicidal, harm to self, harm to others. We're looking into mental health. We're looking into interventions, whether the patient is being followed by a psychiatrist or a therapist, or is there any psychotropic medication interventions has been in place. We look into all of that. We look into the psychological awareness, self-awareness, self-reflection, coping skills. That's all included under the psychological, the mood, the affect, the tone, the verbal communication, the non-verbal communication. How was that really presented itself? Now, we look into the psychosocial emotional. This is where we look at person in the environment, the system within, work, school, family, siblings, support available for them, treatment centers or treatments that have been involved, coping skills that has worked in the past, legal matters that needs to be addressed, CYFD reports, adult protective services reports. Has there been any allegations or any restraining orders against that person or that client or patient? So that's the social aspect of it, emotional. Okay. Spiritual. I added spiritual when I did hospice. We were told not to bring any spiritual into the matter. However, I encourage you guys to touch base on spirituality with your clients as it matters. That's their faith. It gets them through rough and tough situations. A lot of people value that. Explore it. It doesn't have to align with what you believe. But that's what makes it unique and helpful, because it's not about you. It's about your client and supporting them. There has been a time when I was on the oncology floor, I was asked if I could pray with the patient since the chaplain could not make it to the floor. I admitted it. I did not know our prayers in English. I knew all of the prayers in my native language. And I shared that with the client, and I offered that I could say the prayer in Arabic. And client really was happy that I could do that. And then we said it in both languages. So we accommodated, we looked and we assessed and we intervened appropriately, right? So that's the spiritual side. Do not ignore the spiritual side in any settings you are in. Not just because they're not facing a terminal illness, they don't have any spirituality. Because it could be one of their coping skills, and it could help move things forward if you strengthen it and you brought it up to the surface to them. That's your role. Okay. Now, assess the environment. We talked about that. Now, when it comes to documentation, as I've mentioned, with documentation, guys, the chapter reflects on documentations really heavily with profound information and profound knowledge in there. So pay attention to that. However, what I would like to talk to you guys about documentation, most of the agencies that you're going to be working at, they do have the forums and they do have the templates available. So with a click of a button, you can really fill out everything, generate it. Like Epic is one of the systems that I do have those assessments built in and available with a click of a button. I'm easily moving forward through it, and with a narrative being corrected and an AI tool that it could as well fix grammar mistakes or anything like that. So like we've really come far from paper charts to electronic charts. Honestly, I have not ever charted on papers. Most of my charting that I've done since I've started my career was electronically, which is I'm so grateful that we do that. However, we practice for downtime. Downtimes is to do paper charts. So be familiar with those charts. Be familiar where they keep the downtime folder, so you can at least are aware and can fill in those gaps quickly. Now, with documentation, let's get back to it. So now those agencies do have forums. Your initial interaction with your client is the biopsychosocial, right? And tweak that assessment to the settings that you are in. Now, the follow-up visits after becomes a SOAP. That's subjective, objective assessment and a plan. It's a SOAP note. This more of a continuation of what the process is looking like. But don't forget that your biopsychosocial is dynamic and it can be changed, so you can go back and tweak things to it. Now, with your SOAP, absolutely, but it has to be addendum to it. Treatment plan, this is where you document goals, objectives, interventions, and the progress. And as well as with your documentation, what I would like for you guys to know and probably do is make sure your notes are only facts. Make sure to document patient's strengths. Think about your notes as the client is going to read them. And guess what? A lot of those clients do have access to the notes, do have access to their medical records. So think about it when somebody else is reading it, they're not forming an opinion about the client. That's the best way I could say it with your documentation. Don't include any sentences. Include I think, I believe, because it's not about your thinking or it's not about your belief. Okay? Use objective, non-judgmental language. There is a lot of education on appropriate language or terms that shifted from when before it was meant differently and now we have it meant differently. Learn the documentation system in your agency. Ask questions. Ask, since you're the clinician using those tools and assessments available, ask if those can be tweaked. A lot of those electronic systems or EMR do have that feature within it where it can be revised. So the final takeaway for this chapter is systems. Look for interacting influences because they interact with each other and they leave an influence. Now, bias. Check your assumptions. Always examine. Body, assess physical factors. Mind, assess the thought, the mind. Behavior, explore what's underneath it. Environment, look at barriers and support. And documentation, make sure you document facts, context, strengths, and non-judgmental language, and clear and objective. The question that I have for you guys for this chapter is, what area do you notice first? Emotions, behavior, physical health, thinking pattern, or environment barriers? What could you miss by focusing too heavily on one area and leaving the other? So strong assessment connects the person, body, mind, behavior, and environment. What appears be an individual problem may be the result of several factors interacting at the same time. Happy reading and thank you.